Manikana name was there.
So it's 5:01. So shall we start?
Yes.
Yeah.
Yes, sir.
So good morning, good afternoon, and good evening, everyone of the Global Alumni. I think it's indeed a great day for us to restart and reinvent ourselves under the banner of the Coimbatore Medical College Global Alumni. And this is a beginning towards aligning together, networking together, sharing together, learning together. And we will have one session like this every month. And we will be having one of our alumni from across the globe sharing their thoughts and enriching all the others. And I'm extremely delighted and happy that we could start this initiative. Thanks to all the alumni leadership for agreeing and accepting to start this session. And may I request the current president of the Global Alumni, Dr. Ashok Kumar Gupta, sir, to welcome the alumni present today.
Thank you, Bala. Friends, on behalf of the office bearers of the Coimbatore Medical College Global Doctors Alumni Association, I extend a warm welcome to all the alumni across the globe to this, the first of the many such webinars which hopefully will take place in the future. Just a word on the project hygiene, which is now the current raging topic. That's creation of rest areas and renovation of designated washrooms in the hospital. Well, the Dean, Dr. Nimila, deserves praise for her kindness to allow the alumni to undertake the above mentioned project. The faculty appointed by her for licensing with us for this purpose, under the guidance of Dr. Swaminathan, the HOD of Medicine, and Dr. Murthy, the Assistant Resident Medical Officer, along with the Venkachalam, Shanmugavel, and Arul, have been very proactive and very helpful in identifying the apt areas for which will be most beneficial for the CRRs and PGs. I wish to place on record our sincere gratitude to Dr. Swaminathan and Dr. Murthy for their absolute support. On August 10th, during a brainstorming session at a breakfast get-together at my residence of about a dozen of our alumni, including Raghu, Manikraj, Ramurthy, Balavenkat, Murli, and Ahila, along with the Shaktidharan from UK, and an impromptu call with Madhav Ram in Geneva, Bala mooted the idea of having a monthly webinar on a topic of general interest to be addressed by an alumni for the alumni across the globe. This idea of Bala found favor with all of us present there. We were very excited, and it was decided to have the session strictly for an hour, with the speaker being allocated about 30-35 minutes and a question answer session for another 10 minutes. Dr. Ahila graciously accepted to be the first speaker, and so here we are. The plan is to alternate speakers between India and abroad, and we already have a few speakers lined up. On my request, Bala has magnanimously agreed to be the master of ceremonies for all these webinars, and my advance thanks to you, Bala. I wish to make it very clear that these webinars are organized for the alumni. However, everyone is most welcome to join if they so desire. I'm sure the speakers will hold your attention. And I once again welcome you all for the first of many such webinars in the future, hopefully. Thank you.
Thank you, President Dr. Ashok Kumar Gupta, for the proactive initiative, and we look forward to having similar events in the coming days. Now, may I request the Secretary of the Alumni Association, Dr. Madhu Sairam, to give his report.
Hi, friends. Good evening, one and all. It's a great pleasure to be addressing you all as the Secretary of this newly formed CMC Global Alumni Association. This group, as you all know, was formed about 8 months back, and the association's trust was officially registered in Feb 2022 successfully. As has already been mentioned by our president, our goals are quite clear and simple. We work towards the benefit of students and staff of our alma mater, Coimbatore Medical College, and contribute at whatever level possible to make their learning and work atmosphere comfortable. This would in turn result in better patient care. Even before official registration, under the leadership of our president, Dr. Gupta, we implemented some renovation of washrooms in the college campus, and then thereafter continues the project hygiene. An e-library, demo mannequins, and smart boards were also donated to CMCH auditorium, and the current office bearers continue to support and maintain the same. Academics is quite important. A man who graduates today and stops learning tomorrow is uneducated day after. So today we have all gathered online to listen to some interesting information from our good friend, Dr. Ahila Ayyavoo, who is an active member of the Alumni's Executive Council. And as you all know, our alumni are serving in top positions across the globe, and we'll soon be listening to several such academic tops in future for the benefit of current practitioners and students. Thanks for the opportunity. Over to the academics.
Thank you, Dr. Madhu Sairam, for all the activities. And it's important to know that all are busy clinicians, but apart from their clinical work, they do contribute so that as a unit, we can really energize ourselves. And may I request the co-chairman of this academic committee, the vibrant, young, dynamic Dr. Ramalingam sir, the co-chair of the academic committee, to share his thoughts on this web meeting.
Good morning, good afternoon, and good evening to everyone. Thank you, Dr. Bala, for adding me. Actually, I was just recovering from fever, but I wouldn't leave this opportunity to see every one of you, because it seems long time that I have not seen people, at least virtually. And rightfully, you have chosen one of the best speakers, best academicians, Ahila, to give the opening batting lecture. So I was really a bit depressed that we didn't have such activity for quite long time. But now that Ahila is going to start it in a big way, motivating way, for the next speaker to be better and better. So we will try to make it better and better, I am very sure. And looking forward to Ahila's lecture. And what I was thinking is, can we add up the other postgraduates also, so that there will be some amount of competition? So our PGs and CRRs are always informed. Why not add the other PGs, for example, from PhD or KMCH, so that the receptivity will be more, and we are much more happy to share our knowledge with everyone. This is only for consideration, a suggestion, and the chairman, secretary, and the vice president, Raghu, all can decide whether this is acceptable. From our academic side, Bala and myself are willing to go to any extent to do it the way we want. So thank you very much, Bala, and all the office bearers. Let's listen to Ahila. Ahila, the back is with you.
Thank you very much, Ramalingam sir. And before I officially introduce Dr. Ahila, I have great pleasure in announcing the next date and the speaker. The next date is 23rd of September, February, and the speaker is Dr. Shaktidharan Karunanidhi, who is the Director of Public Health of Lancashire, and he's going to speak on how to age gracefully. So some very interesting topic, and We have lined up few speakers from across the globe for the next few years. I also recognize the presence of the founder president of this alumni, Dr. Ashok Kumar sir. Sir, it's such a pleasure to have you with us this evening. Hello. Hello, Dr. Ashok Kumar sir. Sir, are you there with us?
Yes, Balavenkat. I wouldn't.
Can you just on your video for a second? We would like to see your bright face and get inspired.
It is. Thank you very much, Balavenkat, for starting this wonderful program again, Academic Importance, and Dr. Ahila. And my sincere thanks to Sonasite for being the sponsor. They have been supportive from the beginning of this association in our academic activities. And the current office bearers, they are doing a wonderful job to carry the flag of the Alumni Association. And Balavenkat, you have always been the beacon of academic activities. And Dr. Ramalingam being there as a co-chair. And best wishes, and looking forward to listen to Dr. Ahila.
Thank you so much for gracing the evening, and it's indeed a pleasure and a privilege to introduce a very dynamic clinician, physician, researcher who has contributed phenomenally to the pediatric endocrinology in this part of the world and has done extensive research. Currently, she works an alumni of Coimbatore Medical College. She belongs to the 1985 batch. Is that right, Ahila? Yeah, 1985 batch. And she currently works as a consultant in pediatric endocrinology and diabetes at the GKNM Hospital, Coimbatore, and also Aditi Hospital, Trichy. And I just wanted to mention a few things of great accomplishment. This is considered a real major achievement. The John Funder Prize for Best PhD Student Research Publication in 2013 from the Liggins Institute, and nominated for top 18 doctoral thesis at University of Auckland, New Zealand. Heartiest congratulations, Ahila, for making India proud and for also contributing phenomenally to healthcare through your research. She's a recognized guide for PhD in pediatric endocrinology and diabetes by the Tamil Nadu Dr. MGR Medical University at GKNM Hospital, Coimbatore. She's got plenty of publications, and her publications are there in several journals, including JCEM, American Journal of Obstetrics and Gynecology, Clinical Endocrinology, Journal of Pediatrics, Future Cardiology, and many more. And more importantly, she's a person who is pretty vibrant, passionate, and she makes everybody around her completely engaged. This is what I saw in Ahila, and we really look forward to listening and learning from you. Over to Dr. Ahila.
Thank you so much. It's indeed a great privilege and pleasure to be here today. I'm deeply thankful to the CMC Global Doctors Alumni Association. I'm very, very thankful to Dr. Ashok Gupta, Dr. Madhu Sairam, Dr. Raghu, Dr. Ramalingam sir, Dr. Balavenkat, and Dr. Ashok Kumar sir. And it's a real privilege to be here. And I think Ravi Kumar sir is here. If he's there, a special hi to sir too. I'm not sure how interesting it's going to be, but I just, sir, hi sir. So anyway, you will be coming across in a few of the slides also. So I thought I'll say hi to you, because my footprints would be there in all of sir's cases, and sir's footprint would be there in all my cases. So I think it's a very, very dynamic collegiality we have in GKNM, and it's a real honor to work there with all my colleagues and friends who are absolutely fantastic. And I'm also consultant at Masonic Hospital, and I love what I've been able to do for the children with endocrine disorders in Coimbatore and around. The change that they've acknowledged because of this has really made me feel very, very pleased at what I've been doing. I'm just, Dr. Ramurthy sir told me that it has to be for everyone. So I've tried to make the presentation in such a way so that it could be interesting for people across all broad specialties, and may not be very an in-depth analysis, but it will definitely be a bird's eye view of several issues. Just a minute, please. Yeah, it is. Thank you so much for this opportunity, Dr. Ashok Gupta sir, Dr. Madhu Sairam, Dr. Raghu, Dr. Balavenkat, and Ramalingam sir. So I'll just start with metabolic syndrome. What is metabolic syndrome? It is a cluster of the most dangerous heart attack risk factors, which includes diabetes and pre-diabetes, that's even before diabetes, abdominal adiposity, high cholesterol, and high blood pressure. I think that's an International Diabetes Federation's consensus guidelines for the world. So what are the criteria for diagnosis of the metabolic syndrome? We are looking at elevated waist circumference. It's only 85 centimeters and 92 centimeters for either sexes. And I think most of us in South India are actually topping that. South Asian population in the world has one of the highest risk for metabolic disorders, including diabetes. Any other ethnic population for the same weight and body proportion would be at least only at half the risk for diabetes compared to where we are. Elevated triglycerides of more than or equal to 150 milligram per DL, reduced HDL, elevated blood pressure, and elevated fasting glucose of more than 100. So how do we look at this? We are looking at only simple solutions today. And I'm going to talk about what we try to do here in Coimbatore in vis-a-vis what would be done in a well-developed country. So here we try proper diet and exercise, reduce high fat and simple carbohydrate. Maybe we might try a few drugs like fibrates, niacin, or omega-3 fatty acids and statins only in some scenario. And these are for patients with risk factors for metabolic syndrome. So when you have mild to moderate increase in triglycerides, you will have an increased risk for cardiovascular events. When you have severe to very severe elevation of triglycerides, you would be at an increased risk for pancreatitis. The secondary causes of triglyceridemia could be type 2 diabetes, drugs, renal and liver disease, etc. So what can you do in your own house to try to drop the triglycerides in your diet? So when you have milk, the calcium in the milk is the most important part of the nutrition that you would require from the milk. So when you boil milk, it forms a creamy layer at the top. This is due to the precipitation of the protein, and it holds the fat globules within that. So if you skim the milk and take off the top creamy layer, then it becomes skimmed milk and it would drop the fat content and the triglycerides to a significant level. So what are the ways to reduce simple carbohydrates? So these is white bread, sugar, and white flour. What we are using here regularly to drop triglycerides in our patients is we are going back to our earlier days or our ancestral way of eating food, going for complex carbs with varagu, sama, thana, and all other millets, which really have complex carbohydrates, and I found it practically useful in my patients with hypertriglyceridemia. So why do you get elevated triglycerides in type 2 diabetes? Whenever you have insulin, it's extremely important in the synthesis and release of lipoprotein lipase, which breaks down your fat, and this happens in the capillary bed and not the liver. So whenever you have deficiency of insulin, you would have an elevated triglyceride levels. So if you normalize your insulin level, then your lipoprotein lipase will become more active, and that can drop your triglycerides. And there is an offshoot also. There is also heparin, which actually can activate lipoprotein lipase. The next point is medium chain triglycerides is metabolized differently from long chain triglycerides, and use of MCT can reduce triglycerides in the blood, and it can also provide instant energy into any subject. So two ways, you can normalize your insulin and use MCT to try to drop your triglycerides. So you look at simple steps of how to drop. You can drop your fine sugars and improve your complex carbs, reduce your long chain triglycerides or other oil, and go for MCT containing oil, which could reduce the triglycerides again. So we're going to some of our patients and what we did with them. So this is a blood of an infant who had 3 episodes of pancreatitis by 2 months of age, and the diagnosis was familial hypertriglyceridemia. I had taken the details of this child and traveled around the country and via online to all the metabolic consultants I could think of around the world, asking for help with this child. Because this child, by the time the child reached 3 months, had 6 episodes of pancreatitis, and any of them could have proven fatal for this child. So the total cholesterol was 806, HDL was 8, LDL was 369, and the triglycerides were 37,230. You looked at the normal triglyceride cutoff of 150 and look at the triglyceride in this child. The other labs were all normal. So what were the treatment options available? An exchange transfusion. But how long and how frequently? How would I sustain this in the long term? This is just a young infant. Plasmapheresis, again, how long, how much, and how much can I do for this family? And then the metabolic consultant from New Zealand, Emma Glamuzina, helped me, and she said, you can buy Monogen. It's a low-fat formula. It costs $269 for 4 tins, which is equivalent to 21,520. This is probably a bit which could last only for 3 or 4 weeks. And how long can I sustain this again? Fibrates. It is not going to be useful in a scenario like this, where the triglycerides are 37,230. It might be useful in mild to moderate hypertriglyceridemia. They are clofibrate, fenofibrate, gemfibrosal, and some of them, like gemfibrosal, can have quite worrisome side effects. Niacin, some of my patients said they feel so upset with the facial flushing and the GI upset. They said they would never take it again. Statins is not going to be very, very useful in hypertriglyceridemia. So what did we do? So this is what happened to our patient in 36 hours. The whole of the cholesterols had disappeared in 36 hours. So how did we achieve it? We stopped breast milk. We started skimmed milk powder. I looked at all the brands available in India and looked at the constituents of each brand. Sagar skimmed milk powder from Amul costs only 175 rupees for 500 grams, and we gave it through Paladai. I started insulin infusion. I talked to the family. We were very, very open, and we said, this has never been tried before. We are going to try. You have to take the risk of hypoglycemia, and with an informed consent and approval, and then we went ahead with the infusion, but at 1/10 of the diabetic dose. So we went at only 0.005 units per kg per hour, and we monitored hourly blood sugar. Blood sugars, I'm sorry, it's not the blood sugar. The triglycerides dropped from 37,230 to 256 milligram per DL in 36 hours. This child actually had a lipoprotein lipase mutation when it was evaluated earlier. All along, insulin has been useful only in patients with type 2 diabetes, where there is a relative insulin deficiency. It's never been tried in a mutation and a mutated lipoprotein lipase. So I never knew whether it was going to work. We tried and it worked. And now we are using this treatment for all children with familial hypertriglyceridemia around India. And I'm actually helping a lot of consultants from Gujarat and the whole of North India to institute the same treatment, and even in the Gulf from Dubai. So a lot of these patients are benefiting, and I published this in the Journal of Endocrine Society. We managed further by continuing with skimmed milk powder, using lean meat like chicken and fish without the skin, MCT oil for cooking, and we use coconut oil, which has about 60 to 70% of MCT oil, and occasionally 1 unit of insulin whenever the triglycerides go up. That child whom I treated now is 8 years of age, and they don't even come for review because the child is doing so well now. The next scenario I looked at was diabetic ketoacidosis. It's entirely different. You have so many people as a part of the team abroad. You have a endocrine consultant, you have a fellow, you have registrars, you have endocrine nurse specialists, you have diabetes nurse specialists, you have a psychologist. Here in our country and in our own hospital, I'm all in all Aragaraja. So I have to be everything from the consultant to the IR, to the dietitian, to the psychologist. So we have resource poor scenarios. So I wanted to adapt this so that we can improve our outcomes in diabetic ketoacidosis. We have about 600 children in our hospital under my care. And we have at least 50 new cases coming in almost every year, 50 plus new type 1 diabetes coming up in the hospital. So how do they manage diabetic ketoacidosis around the world? They are admitted into the ICU or the HDU, high dependency unit. They give IV fluids, which is either normal saline or ringer lactate. They do frequent blood gases. Glasgow Coma scale is used for assessment of neurology and initiation of ventilation. The fluids are restricted when there is an alteration in consciousness, and IV insulin infusion is used. So what are the points which I actually tried to change was, I wanted to cut the cost and improve the outcomes or keep it as good as you would get in an ICU. I cut down on the number of investigations we were doing. Glasgow Coma scale was initially devised to assess the neurology in trauma patients and has been applied across all scenarios now. How good would it be in children? I was a little bit doubtful. And I shifted from IV insulin infusions to subcutaneous insulin to improve and reduce the cost of these patients. So I admit my patients into the general ward. They stay in the bed next to the nurse's station. The most important points we look at are capillary refill time to assess the circulatory status. The dorsalis pedis and the posterior tibial blood vessels are the most important pulses we look at to assess the adequacy of circulation. The blood pressure. If you have hypotension and bradycardia, we take it as an uncompensated shock. If you have tachycardia and you have a raised blood pressure, we take it as compensated shock. We use the respiratory rate and hydration for treating these patients. Our IV fluids, we've stuck to only one so that I don't confuse anyone. We stick to normal saline, which is still significantly iso or hypoosmolar compared to the circulation, which contains so much of sugar. We do one venous blood gas at arrival. In scenarios where you don't get a gas, you can do an electrolytes and use the bicarbonate to assess the severity of diabetic ketoacidosis. And another 4 to 6 hours later, I ask the mom to call the child. If the child opens the eye, or even if there is a flicker of contraction, I take it that this child should not be ventilated, and I don't use the Glasgow Coma scale. I use subcutaneous insulin with regular insulin every 2 to 3 hours. And I've actually used the same protocol, and my friends in Africa have borrowed this protocol. They said it's very, very useful for their own scenario. So I'm in constant touch with the pediatric endocrinologists in Africa. So we looked at the characteristics of our own patients. We looked at 3 years data when we were shifting from IV to the subcutaneous insulin group. Initially, until all my nurses and all my postgraduates were trained, I was at the background for each patient, for each blood sugar. And once I started having a group of trained people, it's become much more easier. So we looked at 29 episodes of DKA, which were treated with subcutaneous insulin. And we looked at 22 episodes treated with IV insulin. Look at the range of pH. Even pH less than 7 at 6.831 in both groups could be treated with subcutaneous insulin. The insulin dose per day was almost similar, but the time to recovery for the lowest pH was remarkably different for the subcutaneous insulin. I haven't been able to explain this much. Probably it is to do with the family being able to be near the child and reduce the anxiety. It's 35 hours in IV insulin group and 10 hours in subcutaneous insulin group. We looked at the time to recovery. It's about 17 hours in the subcutaneous insulin group and 35 hours in the IV group. But look at the cost. The cost of therapy in Indian rupees for a patient who stays in the hospital for DKA treatment is around 14 to 15,000. When you are treated in the ward with subcutaneous insulin, and it is around 53 to 54,000 when you treat it with IV insulin. So the amount of money is so much different, and we are able to help more and more patients. So I think the p-value shows the difference when you use subcutaneous and intravenous insulin. And I think our team in GKNM is has one of the biggest databases on use of subcutaneous insulin in treatment of diabetic ketoacidosis around the world. There are a few centers in Brazil and some centers in US which use subcutaneous insulin in adults. And all of them have used subcutaneous only in patients with a pH of more than 7.1 or more than 7. I'm the only team, we are the only team who are using subcutaneous insulin, even with a pH of less than 7. Okay, next we go on to a sample of diet which would be given abroad for patients with diabetes. So this has about 1,800 calories and 200 grams of carb. So you have one, what would you have for breakfast? Then what would you have for lunch? What would you have for dinner? And you should also know it's actually pre-cooked food that's quite easily available. One slice of bread across the whole of New Zealand used to measure the same. The amount of carbs would be the same. So much easier to measure and give that. But in India, it is so much different. When I make idli in my house, I would use a proportion of 4 parts rice and 1 part urad dal, whereas somebody would use 3 parts rice and 1 part ulundu. So each one would make a difference. The size of the idli would be different. The size of the idli would be so much in my house, would be so big in Annapurna, would be so small in another patient's house. So it's difficult to count carbs in India. So what do? So we always look at the amount of carb content in the food is how you calculate the insulin dosing. So what we have done differently is we look at, I think everybody is aware that you have a proportion of 25 to 35% of fat, 15 to 20% of protein, and 45 to 60% of carbs. So this is how we write. So we look at the major meals containing, we always use regular insulin because a vial is 137 rupees. A cartridge for a pen would be around 370 rupees. And the pen needles again would be more expensive. A 40 unit vial is available free in the government. So we still continue to use. Vials and syringes for patients who cannot afford pens and cartridges. So what do we say as breakfast? We give the time, we are looking at the circadian rhythm and the counter-regulatory hormones that would be secreted by about 7 a.m. So your cortisol, your growth hormone, all that would alter your blood sugars. So all my patients are taught to have their first dose of insulin by 7 a.m. and their breakfast by 7:15 to 7:30 if they are taking regular, and immediately if it is an analog. So we also tell them idli, dosa, chapati, puri, pongal, and we say, if you take 2 idlis, look at how much insulin you need for your house. If you take 1 chapati in your house, because the size of the chapati can be different between each house, look at how much of insulin you need. So they start writing their records in such a way so that they do it for their homemade food. And what do we give as snacks? We give for vegetarians, we give soya, paneer, vegetables, fruits. And then for non-vegetarians, chicken, mutton, fish, egg, poriyal. All this are what we tell them to take as snacks, and all the patients learn to do this. This is an example of a chart. One of my patients who has a 2-year-old child with type 1 diabetes maintains. So she writes muka cup goduma rava upma, nattu kodi mutta, 80 ml of milk, and each of them, they will also look at their blood sugars. They will learn to adjust their insulins themselves over a period of time. So we have check our blood sugars 4 times daily, and then at 2 a.m. once a week. Then we go on to another scenario. So this is one of my patients who's 10 years of age and who weighed 150 kgs. Obesity is increasingly seen across all social strata in India. And this was one of our prime patients. He was 45 kgs at 6 years of age. The family refused to listen. He came back at 8 years of age with 75 kgs. And at 10 years of age at 150 kgs, Pickwickian syndrome, obstructive sleep apnea syndrome. He had been sitting and sleeping for 18 days. We put him on BiPAP machine and sent him home and got him to lose 30 kgs by only doing diet and exercise. So it is workable, possible only in certain scenarios, but you have to try because you don't have any other option. So what do? We tell them to have a sensible diet, enough exercise so that it contains more than 60 minutes of active exercise, reduction in screen time. Even the poorest family has an Android phone now. So all of them spend a minimum of 2 to 3 hours on screen. Good sleep pattern. Look at your hypothalamus. Early to bed, early to rise makes a man healthy, wealthy, and wise. I think it was probably made up for teaching people about the hypothalamic circadian rhythm. And when the circadian rhythm is disturbed, you can have metabolic disorders. So increase non-starchy vegetables and servings of fruit and reduce the availability of snacks. So this is one of my recent patients referred by a dermatologist, one of my classmates. So this child had extensive hidradenitis, so we could not operate. So we said, you don't have any other option except to lose your weight because of insulin resistance. You were developing all of this. He lost 13.7 kgs in 2 months. From 95 kgs, he came down. And he continues only with diet and exercise. So I have one more patient who's about, she is polycystic ovarian syndrome. Again, she's from a small village near Gobichettipalayam. Look at, they were more worried about her irregular periods. She's got hirsutism, and then she's got acanthosis. She's the same girl. You can look at the earring here and here. It's the same girl and the same scar she has here. In 5 to 6 months, she lost about 8 kgs. She kept on with her exercise. Her acanthosis improved, and we used only anti-androgens and a little bit of OCPs with small dose anti-androgen, because we don't have cyproterone acetate at high doses as can be used abroad. And moreover, it would be difficult to deal with the side effects here. So, and then laser is quite expensive for my patients. So I go with diet, exercise, and a little bit of drugs. So diet, exercise, behavioral therapy, regular exercise, alteration in the diet to saturated, reduction in saturated and trans fat, and reduced glycemic load, high cereal fibers and polyunsaturated fat. And what do we do here in Coimbatore is we just use OCPs and low dose anti-androgens. Laser very rarely for hirsutism, because for 6 sittings, it would cost about 45,000 rupees. So this is, again, I think Ravi Kumar sir knows this patient. So this is one of our congenital adrenal hyperplasia patient. This is how the child looked at birth. This child was initially diagnosed as a pseudo-hypoaldosteronism with severe potassium, 10.7 serum potassium, and cardiac arrhythmia. But this ultimately proved to be a CAH. We did not have to do surgery. On a regular follow-up with appropriate hydrocortisone and fluorocortisone replacement, the child's clytromegaly had regressed. And now this is our standard of treatment. And we do, and the government of Tamil Nadu, the Madurai division of the Madras High Court has passed an order that no surgery can be done on the external genitalia in children in Tamil Nadu without an expert committee recommendation. So we find it very useful that we had already, actually we shifted about 15 years ago away from regular surgery to only surgery when it is required. Okay, this is a very interesting patient of mine. He is, look at his breasts. He's got gynecomastia. He was very, he was really upset. So he's a 10.5-year-old boy. He had gynecomastia and sudden increase in height, but he didn't have any other features of puberty. No facial hair, axillary hair, pubic hair. His testis was prepubertal. His stretched penile length was normal. The systemic examination was normal. His LH was not definitely pubertal. It was neither here nor there. His estradiol was slightly high. It is usually unrecordable. The testosterone was again normal. He had a normal ultrasound. Karyotyping was 46XY, and we were tearing our hair apart. So we just went back and retraced the whole path from the beginning. And what were they using? This boy, this family was into natural products, and he was using moisturizer made with Himalaya, which had one of the constituents was lavender oil. Both lavender oil and tea tree oil have phytoestrogens, plant estrogen, and that was the reason for his gynecomastia. We took him off his moisturizer and he became well. You can also have xenoestrogens, chemical estrogen from use of plastics, but this boy's phytoestrogen was coming from his natural oil. I've got only 2 scenarios. So this is something which you would see regularly. A 28-year-old woman, her BMI is more than 95th percentile. Her T4, total T4 is normal. Her free T4 is normal. Her TSH is marginally elevated. She was started on 12.5 microgram of thyroxine. This is absolutely rare to require such a low dose in an adult. So everything is fine except for a marginal elevation in TSH. This is usually due to a leptin-like reaction which comes from the obesity, which stimulates the production of TSH. This is probably an obesity-induced hyperthyrotropinemia, You don't need thyroxine replacement. I took this lady off that, asked her to diet and exercise regularly, repeated her thyroid function test, and it was normal. So you didn't need replacement for this lady. So this is my last scenario thing. So it's an 18-year-old lady, constipated, tired, sleepy, an alteration in her menstrual cycle. She had gained 6 kgs in 6 months. She was not exercising. She was tired, so she was always sleeping. Her T4 was low. Her TSH was normal, but the other systems were normal. So there could be 2 scenarios which could cause this. One is a very sinister scenario. In a patient who was previously well, when you suddenly drop your total T4 and free T4 in the presence of TSH, it is a CNS tumor unless proven otherwise. But in this patient, the free T4 was normal. So that takes away that diagnosis, and it was actually a thyroxine binding globulin deficiency. So the active form is still normal. The free T4 is normal. TSH is normal. This patient did not need any replacement, and this was only a TBG deficiency. Look at situations from all angles, and you will become more open. From Dalai Lama, and I thought that was really open. And I used one Tirukural in my PhD thesis when I submitted. Epporul yar yarvai ketpinum apporul meipporul kanbadarivu, which I think applies to all scenario. And I will go back to what Dr. Ravi Kumar sir always tells us. Whatever you believe is true today would be negated tomorrow. Science is negation of what is right today. So I would go with both Dalai Lama and Ravi Kumar sir for those wonderful sayings. And thank you so much for the patient listening.
Thank you, Dr. Ahila, for that very lucid presentation. And you made it very simple. And I think a lot of innovation, a lot of thinking has gone into whatever you spoke. And then you indigenously, you have tried several things which have been very good. And most importantly, you published that. And I think as a country which is really trying to show up in the Committee of Nations, publications like this will put India first. And we are very happy for you doing a lot of this good work in not only treating patients, but also publishing it, and for sharing those excellent insights and inputs in this today's session. And I'm sure this is the beginning of a journey of learning from each other. And thank you for accepting to be the first speaker, because, until it becomes popular, the numbers may be less. But then we need to make a beginning, and you gave us the good start. And we look forward to learning more from you. And now the topic is open for discussion. Anybody wants to ask the question, can either put in the chat box or can ask the question directly by raising the hand.
Ahila, can you hear me?
Yes, sir.
Yeah, it was wonderful and very nice you put all the facts. The one thing which we are finding it difficult is quite a number of population are becoming more and more obese. Whatever amount of advice you give, they are not listening to us, at least in our part of country. So do you want to involve a psychologist or psychiatrist to make them really understand what it is? Really, they don't understand what is the long-term consequences they are going to face, and how long will you have time to really convince? If you do it, that's wonderful. But do you think psychologists or psychiatrists should be useful?
Thank you for that lovely question, sir. I can see Lakshmi Shanti, Dr. Vijay Giri, Dr. Manikraj, everybody in this group were all, and Ravi Kumar, sir, they all know my pattern of talking. So initially it talks with a very mellow talk, and then I become very rigid. Then I think that actually works. I spend at least an hour per patient. I don't mince my words, because I'm seeing what I predicted 10 years ago for my patients is something which I'm seeing right in front of my eyes. I'm seeing obstructive sleep apnea. I'm seeing chronic kidney disease. I'm seeing established diabetes, retinopathy, nephropathy, everything I'm seeing right in front of my eyes now. So whatever I said I don't regret being rude when I spoke to all my patients. All my patients come back because they remembered what was said. I would say our success rate is not bad. At least 50 to 60% of our patients achieve significant weight loss. Even 5% weight loss would improve your metabolism by about 20 to 30% or more. So it is not going for your ideal weight. Even 5% from what you lost, what you have now would definitely improve your metabolism. So I mean, all the pediatricians, including Priya Viswasam and everybody who's on this group today, will know how I talk to my patients, and they just get it badly from me if they don't listen to what we say.
And how long will you wait for them to really understand they have to reduce the weight drastically, at least say for 6 months or 1 year, or you will go for an advice to reduce the weight by bariatric surgery? Do you ever advocate?
I have not advised any adolescent so far for bariatric surgery, but yes, young adults, yes. Only after they've completed growth, I've sent some of my patients for bariatric surgery, but they would be minuscule. Probably I would have sent 4 or 5 patients, and all of them were like 18, 19, 20. Beyond 20 is where I've sent them. I haven't sent them earlier than that, and I haven't sent much for bariatric surgery. But yes, that is definitely an option. But I'm also trying to work with the GEM team to see if I can instill a balloon temporarily for 6 months and take it off, so that you could achieve significant weight loss without the trauma of surgery.
Thank you.
It's really nice to see Dr. MR joining us. MR sir, such a pleasure to see you, and the Dean of Pediatric Medicine of the city joining us. And we had such a wonderful talk by Dr. Ahila on the diabetes.
Sir, your mic is muted. So you're muted, sir.
MR sir, you are muted. You have to unmute yourself.
I know Dr. Ahila is an excellent speaker. She can speak with conviction. She can speak with conviction on both type 1 diabetes mellitus as well as obesity. And I have known her work for almost a decade. Indeed, in the management of diabetic ketoacidosis, she has simplified the whole management in such a way that even an average practitioner in the periphery can do it without much of an expenses and without much of a complications. So I'm really very happy to participate in this. Thank you.
Thank you, sir. Dr. Ahila, one question to you. See, always when you keep lowering the values, like the fasting and the postprandial, we see so much happening. I think it's possibly because of the data that is collected and then seeing the complications. For an Indian population, what do you think is the right guideline to term them as a diabetic based on the fasting, postprandial, and the HbA1c? And once they're a diabetic, which is the kind of for monitoring HbA1c, do you consider it good? And if it's good, what do you consider it as a good value?
So for our type 1s, actually, anyway, both type 1 and type 2, the targets are the same. The American Diabetes Association recommends less than 7. I look at 6.5 and less. I've got patients who have been able to achieve 4.9 only on pens. They're so good at their blood sugar monitoring and their diet and exercise and all that. For the fasting and the postprandial, I still stick with the international recommendations of more than 126 fasting and more than 200. And for diagnosis of diabetes, HbA1c of 6.5. But my goals for treatment and achievement of a good health is not only having a good HbA1c, 70 to 80% of blood sugar should be within target. So my target is 80 to 160, at least 70 to 80% of time to reduce your long-term risk. I tell all my patients, you've got your whole life ahead of you. If it's a 2-year-old child, this child has around another 90 years to go. You can't have bad control now. So we look at 80%, at least 70 to 80% in target, because if you have lows and highs, the HbA1c would be good and maybe a good average. So you need to have glucose in range and also a good HbA1c to have a good outcome.
One more question, Dr. Ahila, is like you see diabetics living until 85, 90 years, we get them for hip fractures and having an erratic HbA1c, but still having led a life the 8th decade and the 9th decade, which means, is there something, there is a genetic predisposition to develop vascular disorders apart from these values?
I would say actually everything is, it is not going to be a general treatment for anyone in the world now. It is to be tailored for each person. Your genetics will determine your response to each of your drugs and your medications. The future is going to be tailored to each person's requirement. So there might be some, a genome-wide association study may show up something in future. For now, we haven't been able to pick up anything specific. I think some people have raised their arms, Dr. Ashok Kumar.
Yeah.
Dr. Ahila, I have a question to ask with respect to type 1 diabetes mellitus. When you are, when you want to really have a very strict, rigid control of this, blood sugar level, what is the price you pay for in terms of hypoglycemic episodes? I'm always concerned as a practicing pediatrician. Hypoglycemic episode is far more serious than occasional excursion to hyperglycemic range. What do you think?
Sir, occasional excursion of blood sugar is okay, but you can't keep on having lots of 200s and 300s. It's ultimately going to damage both your eyes and your kidneys and your other microvasculature. When you check your blood sugars frequently, the number of hypos definitely go down. The future abroad is insulin pumps with an associated sensor. You have hypoglycemia suspend option on those pumps, and you have a small microboluses being given by these pumps overnight when you have a high, but that is not for everyone. So that way I prefer frequent blood sugar checks, and then all the family learn what happens with each type of food and what happens during illness like diarrhea and vomiting, and what happens during periods of other illness like high-grade fever and cold. And they learn to adjust their insulins for that.
Okay. So thank you. Thank you.
Dr. Ashok Kumar, sir. Sir.
Thank you, Dr. Ahila. It's commendable to see your work in the area of subcutaneous insulin. It's wonderful. I have a couple of questions, actually several questions, but I'll ask only a couple of questions to others to ask the questions also. This is about diabetic ketoacidosis, what you're talking about. Probably there is a difference in pediatrics and adult management of diabetic ketoacidosis because of the basic cardiac function. In adults, there's cardiomyopathy, previous MIs, and so on. What my question is about IV bicarbonate. There is no particular study to show that IV bicarbonate is useful, but here in this country, they still use IV bicarbonate for pH less than 6.9. There's no data to show that that's useful. But I'm glad to see that you didn't mention about that. The second question is the IV fluids. What do you use to guide IV fluids? When do you stop? When do you decrease the rate of IV fluids? And also subcutaneous insulin. Have you seen any post-management complications, in the sense, is there a rebound hypoglycemia? In hypotensive patients, there's a peripheral shutdown of vascular system. So when you give subcutaneous insulin, when the circulatory system returns to normal, do you have increased absorption? And do you see any hypoglycemic episodes after? And also in the adult ICU, in diabetic ketoacidosis management, we do see post-management pulmonary edema because of excessive crystalloid use. So some institutions use IVC collapse as a monitor to guide IV therapy. So I know I'm throwing too many questions, but these are all only, there's no data, there's no controlled studies to show any of these are important. So I just want to hear your views on these things, Dr. Ahila.
We don't use bicarbonate at all, except after initial 8 to 10 hours of fluid. Then if they continue to have severe acidosis, we look at scenarios like lactic acidosis from severe sepsis, or renal dysfunction. These are the only two scenarios where I use bicarbonate, but never in the initial 10 hours. Next, I actually use subcutaneous insulin. The most important focus for our treatment is fluids. So we are very, very slow with the fluid input. We are taking 48 hours to correct fluids for children over the age of 5. We take 72 hours calculation for children under the age of 5. So our fluid input is extremely slow. We take our first dose of insulin based on the severity of the dehydration. If the dehydration is severe, we would give one bolus of 10 ml per kg. We don't go much. If we are in severe shock, we push 2 boluses. And after that, only after the circulation picks up, we give the first dose of subcutaneous insulin. So the first dose insulin comes after stabilization of the circulation. We don't give insulin before the stabilization of the circulation. If the patient is in severe shock and does not respond to 2 boluses and third bolus may be tried, but then by then we would have ventilated and we would have stepped into also inotropes. We don't use too much of colloids also. We are very, very careful with that. Touch wood, so far so good. Over the last 8 years, I've not had a single cerebral.
Excellent. Thank you, Dr. Ahila. We move on to Dr. Sumati Lakshman. You have a question?
Yes. Yeah, I just have one question, please, which is about the subcutaneous insulin and IV insulin therapy. And I can see that it's mentioned that with subcutaneous insulin, the recovery is within approximately 10 to 12 hours. And in the IV insulin category, the recovery time is up to 35 hours. And I just want to know what is the major contributory factors which is making the difference between the subcutaneous and the IV therapy taking a longer period of recovery.
Actually, we had discussion and then I was bouncing back and forth with the discussions with several people. The only explanation I could offer was in the general ward, when the children are admitted for subcutaneous insulin therapy in the general ward, all the family members are around the child. Whereas when you are admitted into the ICU, you have only one family member and they may get up, go out, come back. The children become more anxious. They can have counter-regulatory hormones like adrenaline and cortisol pushing in and probably not allowing the blood sugars to settle very fast. That was my only explanation I could draw. I couldn't offer any other explanation for that.
But we haven't measured the cortisol level to back up
I'm cutting my costs. I don't do any investigation unless absolutely necessary, which will help my patient survive.
Okay.
Thank you so much, Ahila.
And also, I'm very, it's quite interesting to know the Indian Daphne regime. I would call Dr. Ahila's regime, dietary regime as an Indian Daphne regime. And I think it will be very useful to the Asian population who are abroad, because the diabetic dietitians we have here are mainly tailored towards a Western diet, and they can't specifically, advise in terms of the dietary control for the Asian population. And this one is very useful and it can probably be pushed to the Asian population abroad as well.
Dr. Sumati, why don't we do a multi-centric trial with Ahila as the principal investigator? And Ahila, you need to patent your dietary regimen. Otherwise, you will see a study.
Indian Daphne regime. And I work in the community as a primary care physician, and we have a lot of difficulties admitting Asian patients, especially Asian women, like from Pakistan or Bangladesh, to go into hospitals and to follow instructions correctly. And these patients will be, they will benefit a lot because even though they are abroad, they still eat the idli and chapatis and dosa and all the fried food, unhealthy food. It will be very useful. And I am very happy to look into that.
Okay, just one point before I think the next question comes on. In 70% of my patients, idli and rice does not cause too much of excursions in blood sugar. Chapatis and wheat products actually increases the blood sugar. I don't know why. So, and 30% is the other way around. So because there is a traditional thinking in India where you always say you eat wheat or chapati sakara better. And then when you go to North India, they always say if you eat rice, you'll become better. I think basically people just want to torture others by giving them what they don't want.
Yes.
Thank you for that philosophical thought as well. And welcome to Dr. Einstein Arunachalam from US, who is currently in India, to share his question.
Thank you, sir. Excellent talk by Dr. Ahila, especially giving various clinical scenarios, and it was clinically based. One of the question was, how often do you give the subcutaneous insulin, and how often you measure the blood glucose level when compared with the IV insulin, and how often you check the potassium and all those things? Because here in the US, in the floor, they cannot monitor the serum potassium, blood glucose, and everything every hour, because floor they monitor every 4 hours or something like that. But in the unit, that's why we put the patient in the unit, so that the nurses can monitor every hour and replace as necessary. So that was one of my questions.
Thanks,
Thank
Einstein.
you.
Nice to talk to you again. So Einstein is my good friend and my classmate. So we check one electrolytes at the beginning. When I use normal saline, I have a clinical pathway protocol drawn for the hospital, which I train all my postgraduates and nurses in the protocol. And I'm at the background for them to ask any question at any point in time, day or night, every day. And that is how I've trained all my team. So what do? We do only one electrolytes 4 to 6 hours later. We give regular insulin, means every 2 to 3 hours. For the first dose, it's 1.5 hours from the first start of IV fluid once we stabilize the circulation. The next dose will be 2 hours later, and subsequent doses will be every 3 hours when we use regular insulin. Very, very, very rarely, I would say less than 1% of my patients, we have used analogs because they are much more expensive. Anyway, I use a 40 unit per ml vial and a 40 unit per ml syringe, because I can even take half unit on that. We don't get half unit syringes in India, so the needle may be a little bit big. The only thing which I don't compromise is hourly blood sugar. I do an hourly blood sugar for each of my DKA patients. We buy the glucometer immediately, so the cost comes down immediately. I have an ongoing understanding with Bayer, where they supply the meters free for all my type 1 diabetes patients, and the strips are extremely cheap, or the cheapest in the whole of the country. So we don't compromise on blood sugar checks. I do only one electrolytes 4 to 6 hours later. If there is an issue, I will repeat it later. If there are no problems, I don't repeat it after that.
Excellent. Thank you, Dr. Ahila. I think that's been a very stimulating session. And can I request Dr. Vijayagiri to ask his question?
And thank you, sir. Thank you, Dr. Ahila, for a wonderful talk. And thank you for taking care of a lot of my patients. Ninga sonna mari, you give wonderful counseling. Ninga titra mari irukom, but usually patients come back positive, lot of positive about you, madam. They like your counseling. Ninga endha way harsha ninga sonnalum, they like your counseling, madam. And it was an eye opener for me also regarding the gynecomastia, applying moisturizers and phytoestrogens. Thank you, madam. Thank you for the wonderful talk.
Thank you, Dr. Vijayagiri. Dr. Madhu Sairam, you had a question to ask? Yeah, I think he has put it in the...
Yeah, between high sugar food and high fat junk food, I think there's not too much of difference. Both are equally harmful and bad.
Excellent. I think we had a wonderful academic session together. Great beginning, great speaker, good content, nice participation. And I'm very happy that true to its sense, we had questions from US and UK. And I'm sure that forthcoming meetings will also generate equal interest and more participants. And like Dr. Ramalingam sir said, I think we can open up because knowledge shared with anybody, I think anybody getting any gain out of listening to the talk, some patient is going to get benefited. So Ramalingam sir, I think this platform can take 1,000 people. So we can open it to as many people as possible. And this is kind of an academic charity to people who wanted to listen and learn from this. And Ashok Kumar sir, President sir, will agree that we can share it with everybody. Thank you, sir. Thank you so much for that. And
Just one comment, Balavenkat.
yes, sir.
Because a talk like this, which is comprehensive, many PGs can listen to wherever they are. Let us give the first option to number of PGs, and then let us fill up with the rest of 1,000 slots. So,
Sir, and also I wanted to add, the whole thing is recorded, and this will be passed to the SOMI committee, Dr. Kannan, and this will be available in the YouTube continuously for months together. So even if somebody has not been able to come or miss that event, still it can be heard.
yeah, that's nice. That's nice.
Yeah, yes, sir. President, sir.
There's a question from Ravi Kumar for Ahila. Maybe you can look in the chat box and answer that too.
Yeah, sir has asked, if the HbA1c is between 6 and 6.5, do you put them on metformin? Sir, you know my protocol. Yes, for patients who are obese, who are on the verge of becoming a diabetic, I put them on metformin. Remember, diet and exercise form the primary treatment modality for all these patients. But the addition of metformin can postpone the onset of type 2 diabetes by a little while. We do use metformin. It's old as gold, 100 years old now, safe. You know where the toxicity, it's a known devil. I always say, so that way, I think it's a very, very useful drug and one of the safest drugs I've ever used compared to anything else. I mean, beyond thyroxine.
So thank you so much, Dr. Ahila. And truly, it was a very, very stimulating session. And I failed to see Dr. Raghu there. Sir, is he operating or is he available?
He is operating.
Okay. Okay, sir. So I think as we planned, we will have very precise sessions about an hour and 15 minutes. And I think the session was really, really wonderful, Dr. Ahila. I think we'll get you back again sometime in due course with more audience. And but we need to have a beginning, and you gave a good start. And well begun is half done. And we go very content today that we had some very senior members participating. And Ravi Kumar sir, MR sir, the doyens of pediatric medicine and surgery in the city of Coimbatore. And I see a lot of comments coming in. And thank you so much for your time. And I wanted to tell you, just got a message from Dr. Shaktidharan and the next speaker. And he would prefer it to be the 24th of September. That's a Saturday evening, 5 p.m. IST, rather than Friday, because he's not he feels that would be more convenient. President sir, can we fix it for 24th of September, Saturday evening, 5 p.m. IST to meet again and learn more? And we'll make sure that, Kannan, I think we'll go for registrations on a platform so that we know who all attended. And also, I personally feel we will generate a certificate on behalf of the alumni for every guest lecture that is provided for record purposes, and also for making sure that we acknowledge the time and the effort made by the speaker. So thank you so much, Dr. Ahila, with us. And
before we close, can we have
it is
everybody
honoring them also.
faces, actually, we'll take
It's nice gesture to honor them.
Annan, I can't hear you well.
Sir, before we close, can everybody show their faces? We'll take a screenshot of the screen.
Yeah, so the request is, yeah, that's right. Yes. All those who are present here, can you just put your video camera on and
Wonderful.
yeah, Dr. Siva Subramaniam, Dr. Lakshmanan, Dr. Priya, Dr. Ratna Swami. Can you all switch on your videos? Yeah. The whole area becomes so bright. So many people. Yeah, Dr. Lakshmanan, Dr. Ratna Swami. Yeah, is put on.
Yeah, so
Yeah, shall we
thank
go
you
for
so
the
much
shot?
for all the
Yeah.
kind comments.
Okay. So, Kannan, have you done the job?
Yes, sir.
Okay. So, my sincere thanks to all those who participated in the first academic session of Alumni. And so you will be getting the intimation for the next session. That will be 24th of September, Saturday evening, 5 p.m. IST. And until then, we look forward to your active participation in the alumni activities. And if you have something to contribute, please do not hesitate to contact the President, Secretary, and the Vice President. And once again, sincere thanks, Dr. Ahila, for doing that wonderful talk. Absolutely brilliant. And you answered the questions equally well. Thank you so much.
Thank you,
And bye until we meet again on the 24th of September, 5 p.m. IST. Thank you.
Thank you,
Bye-bye.
everyone.
Thanks,
God bless
thanks,
everybody.
Balavenkat. Thanks,
Thank you
Akita.
all.
Thank you.
Thank you.
Thank you.
Thank you all.
Thank you, Bala. Thank you very much.
Thanks, Dr. Bala.
Thank you.
Thanks.
Thank you, Savita. Thank you very much.